One more minute. It's exactly 8 a.m. I believe at your place now.
Yeah, you're right.
Okay, so I think we are live. All right, welcome, ladies and gentlemen, to the webinar on distal radius fractures. And we're very delighted to have with us two luminaries in the field of hand and wrist surgery. We have with us Dr. Sanj, Professor Sanj Kakar from the Mayo Clinic, who needs very little introduction, and our very own Professor Anil Bhatt from KMC Manipal, who also doesn't need more introduction than what I'm just going to present to you. So the Pune Orthopedic Society decided to use the social media platform as well as Zoom meetings to reach out to its members and audience in an attempt to carry on with academics, which is perhaps the primary responsibility of any scholarly or academic society. And the pandemic proved to be a challenge, but also an apt opportunity to advance science and knowledge through collaboration, even across the 7 seas with our colleagues and friends, share knowledge and keep learning. So this is a brief video of the Pune Orthopedic Society. We are a dynamic society where we are now going to use social media as well as Zoom platforms to advance knowledge and science via webinars, case presentations, case discussions, journal clubs, and so on and so forth. I'm very proud and very privileged to serve as a secretary of the society along with our honorable president, Dr. Narayan Karane, and a very dynamic team of executive committee members who are very active in advancing academics. And this is our society with the current EC executive committee members who have been a pillar of strength in getting things done and organized for us. So without further ado, I would, with great pleasure and a distinct sense of pride, like to introduce Professor Sanj Kakar. So although Sanj Kakar is a very illustrious hand and wrist surgeon, but more than that, he's a very dear friend. And at a very short notice, he agreed to talk to us and share his knowledge and experience from distal radius fractures. Professor Sanj Kakar is an internationally recognized leader in orthopedic hand and wrist surgery. He serves as a consultant in the Division of Hand Surgery and has also served as a past vice chair of Clinical Practice Committee in the Department of Orthopedic Surgery at the prestigious Mayo Clinic, Rochester, Minnesota. He currently also serves as the editor of Hand E of the American Society of Surgery of the Hand and is the medical director of digital professional education at the Mayo Clinic. He is a member of several academic societies and learned bodies and serves on the boards of many of these societies, including the American Academy of Orthopedic Surgeons, the American Society of Surgery of the Hand, the British Society of Surgery of the Hand. He is very active in clinical research and has more than 200 peer-reviewed publications. Dr. Sanj Kakar has not only completed his medicine and his MRCS from England, but he went on to do his MBA, his orthopedic residency, and then a fellowship at the Mayo Clinic before joining as staff and attending at the Mayo Clinic. This session will be moderated by a very dear friend again, and I'm so proud to be to call them as friends as well as colleagues who have in very many ways helped me learn and advance my knowledge, and to which I'm very grateful. Professor Anil Bhatt, who will be moderating this evening's session, is professor and head of the Unit of Hand and Microsurgery and the Associate Dean in Kasturba Medical College, Manipal. He very categorically asked me to be modest about introducing him. but suffice it to say, he is a very erudite and a very learned, very exceptionally gifted surgeon, besides being an exceptionally gifted culinary expert. So I would like to also take a moment to acknowledge the makers of New Drug Pharma, who have generously given to support our educational activities. Professor Bhatt, I would like to invite you, please, to take over the proceedings of the evening and conduct the webinar. Thank you very much.
Thank you, Abhijit. Thanks to Pune Orthopedic Society for this invite and opportunity. And I think it's a Valentine gift to connect Sanchiti, Manipal, and the Mayo Clinic today. And we are really grateful for that. As a postgraduate, I was always told that fracture neck femur is one of those unsolved fractures, fracture of necessity. And when we started looking at distal radius in the upper limb, I still feel it's not probably a fracture of necessity, but probably one of those unsolved fractures. Fracture neck femur probably is almost solved. But fracture distal radius, every time I attend a seminar or a webinar like this, I keep learning more and more. And I think today, Sanj, Prof. Sanj, with his huge experience and his work, will probably solve some of those jumbles which we still are in. Over to Prof. Sanj for your talk.
Thank you, Neil and Abhijit, and I'd like to thank all the listeners for joining today, and most importantly, the Executive Committee and the President of the Pune Orthopedic Society. It's really an honor to be here today. Distal radius fractures, as Professor Bhatt mentioned, is a huge topic. And so what I wanted to do today is to try and give you some real life tips and pearls to try and keep you out of trouble when managing these fractures. So I'm calling you today from Rochester, Minnesota. I looked at the weather forecast today in Pune. It's 82 degrees Fahrenheit. It's minus 40 degrees Fahrenheit here today. So there's 120 degrees Fahrenheit difference between where you are and where we are. So in terms of Mayo Clinic, just briefly, the history, these are the three influential people. You have William Mayo in the center, and his sons, William and Charlie, who founded the clinic back in 1889. And our first chair of the Department of Orthopedics was Dr. Henderson. And when you look back at the history, he was one of the founding fathers of the American Academy of Orthopedic Surgeons back in 1931. Look how far we've come since then, with the privilege of being able to share knowledge both from here to you and from you to us. In terms of the department, you can see we have a large department, and I know many of you know our colleagues and friends within the Department of Orthopedic Surgery at Mayo Clinic. And in terms of the division of hand surgery, we have 11 wonderful partners, and our area of expertise sort of gamuts the whole upper extremity, and Dr. Marco Rizzo is our division chair. So my goal today is to share with you some tips and tricks that I've learned along the way and hopefully can help you moving forward. These are my disclosures. And, you know, I have many friends in India. This was a long time ago, where I think in 2017, when I had the privilege of being at the Indian Society for Surgery, the hand meeting in Mumbai. So such a long time ago, but even though we're spread by geography, we're always close together by heart. Again, this is a massive topic. So to do this in just under an hour is difficult, but we'll give it a go. Some of the literature is published on this to help you moving forward, and hopefully that will help you reinforce some of what we're going to discuss this morning, or this evening for you, this morning for me. So these are the objectives that I wanted to sort of go through, really basically allowing you to understand the nuances of the different types of distal radius fractures. And when you understand that, you can apply the appropriate treatment methods and try and give you some tips and tricks also within the operating room. So when we think about the anatomy of the distal radius, we always look at the radiocarpal joint, but what I would caution you is look at the sigmoid notch, because that is key for pronosupination. And 20% of the stability of the DRUJ is at the sigmoid notch. So it's not the biggest part, but it's certainly the foundation of the DRUJ. So just keep an eye on the sigmoid notch, and we'll talk about that in a little bit more detail. And these are the goals of treatment. We want to get the joint as close as possible, and the anatomy of the distal radius, especially in height, as close as possible to the uninjured side. But the first question is, do all distal radius fractures need surgery? And I think many of us will say no, which is true. But there are some that you need to watch carefully to predict who will work and who will not work with non-operative treatment. There's many classification systems out there. This is the Lafontaine criteria, which basically looks at, once you've reduced the distal radius, you look at several criteria. And if it's more than 3 of these patients will tend to fail non-operative treatment. There's another classification described by Margaret McQueen called Carpal Malalignment, which we don't really think about. So if you look at this, it's based on radiographs, but I wanted to show you the CT. It shows it more eloquently. On the post-reduction CT or X-ray, if you draw a line down the longitudinal aspect of the radius and a line down the longitudinal aspect of the capitate, these lines should cross and intersect within the carpus. And you can clearly see that these lines do not cross. They should cross roughly where that lunate is. And this is a marker of carpal malalignment, which is an indicator for operative intervention. So again, do this on your post-reduction radiographs. So I want to share this study about why that Lafontaine criteria is important. So this was a study many, many years ago, but I think it's important to look back at history because this does describe how we move forward. So we had 50 patients who underwent a closed reduction and had more than 3 criteria for instability. And what they notice, if you follow these patients, even though that they look good within the first week or 2, is that they can fall off up to about 3 weeks after the reduction. And age over 50 is the most important determinant for failing non-operative treatment. So it's critically important when you treat these patients non-operatively, especially if they're over 50, you need to watch them carefully weekly with sequential radiographs to make sure you don't miss them. Because this is what can happen. This is a patient that came to see me, had a distal radius fracture treated non-operatively, and the first week the radiographs actually looked pretty good. And then at 6 weeks was then seen back by her treating physician, and you can see that that reduction is completely being lost. And so she has a distal radius fracture malunion, and she also has arthritis within the wrist. But remember, I talked to you about the DIUJ. If you look at the axial CT in the bottom right, you can see how there's instability of the DIUJ. And this was her biggest problem, a lack of pronosupination. So this is why you have to follow these patients carefully. How did we treat this patient? So with this, we wanted to do a multiplanar corrective osteotomy. So we use these technique guides, and now with 3D printing, it allows us to really sort of mirror what the abnormal to the normal anatomy is, and then obtain your selective cutting guide. So here you can see the guide is being placed. And then now we're making this biplanar cut. You can see there's 2 osteotomies in the radius to allow us for the correction of her radial height and inclination and the volar tilt. So that's about non-operative treatment. What about the operative indications? So this is the indications from the American Academy of Orthopedic Surgeons, and I think it still holds true today. And I've just listed this here for your understanding. But there are a myriad of different treatment methods of how to treat a distal radius fracture, from cast treatment all the way to fragment-specific fixation. And I think if you're taking care of these patients, you really should be familiar with many of these, because not one fracture treatment suits all. And it's very important to individualize the treatment based on the fracture, the patient, and also your surgical skills. I think the latter is important. And if there's an area that you feel that you need further training, I think you should get that, because not every fracture, for example, is amenable to a volar plate. So let's run through some of the examples. What about dorsal plating? Dorsal plating has received a bad rap. And why is that? That's because of its symptomatic hardware. It's something we often don't do nowadays, but if we do it, the indications of what? I think essentially, it's when you have a concomitant dorsal injuries, for example, a scapholunate ligament injury, where you can address everything from the dorsal approach. The main complications are symptomatic hardware. Now, this has changed because the plates are now lower profile, but I think it's important, if you are placing these plates, you have to follow these patients for symptomatic hardware, because otherwise they'll have tendon rupture. So this is a study by Tamara Rosenthal out of Boston, looking at 2 types of plates, the one which is higher profile and the other one which is lower profile. But you can still see, and nearly a third of patients needed to have plate removal because of symptomatic hardware. So if you're going to put a dorsal plate, watch these patients very carefully. So look at this patient. This is a patient of mine. You can see has a distal radius fracture. And you can see the CT scan here. So you can see it has that dorsal ulnar corner fragment. And this is a fragment that whenever you have this, you need to respect this because this forms a sigmoid notch. And I thought I could get this from the volar approach with my screw going from volar to dorsal. So here's the plate placed. You can see I've got provisional stability, but one of the tips that I wanted to go over today is critically look at your x-ray. So when I look at the x-ray, you can see that there's a double density there of the sigmoid notch. So that means that I'm off either volar or dorsally. Now I'm at the volar side, so I'm looking at it. So I knew I was off dorsally. So here what I did is reduce that dorsal ulnar corner, put my screws in, but I kept the volar ulnar corner screw short. And then I went dorsal and captured that fragment. And now you can see the sigmoid notch has been reduced. But I mentioned to you about symptomatic hardware. So one of the tricks that you can use is, number one, use lower profile plates. But number two, you can split the extensor retinaculum so you cover the distal aspect of the plate and protected the tendons. So what about volar plating? I think this needs no introduction because this is obviously what a lot of you use today in your treatments. And there's numerous advantages, as by going volar, you have a nice soft tissue envelope to protect the plate. And by using a fixed angle construct, you can allow these patients to move early. And this works very, very well in the vast majority of fractures. However, there are some nuances of this. If you place this too distal, past the watershed line, and I'll go over an example of how to avoid that. You can put screws within the joint. And also if you go past the watershed line, the plate can be proud volarly. So not only are you worried about dorsal tendon irritation, for example, if the screws are too long, but you can also worry about volar plate irritation of the flexor tendons. And this is the critical view of the anatomy of the distal radius and why you need to make sure your screws are not too long. So if you look at this plates being placed, you can see when you actually see the screws in the second and fourth extensor compartments, invariably they can be long and you get fooled because of Lister's tubercle. So when you're taking your x-ray, you have to get multiplanar fluoroscopic images to ensure your screws are not too long. So in terms of tips, tip number one, most importantly, you have to be able to see what you're fixing. There's no point putting this plate on. You can see this patient was sent into me where the surgeon just put the plate on, but didn't get a reduction. So the key thing is to get a good exposure for what you're doing. And this is a nice example by George Orbe, and I wanted to show this and share this with you with the extended FCR approach and show you some surgical nuances. So the difference of this approach is this distal aspect. You can see it crosses the wrist crease. And this extra inch is critical, especially to ensure that your plate is placed appropriately distally for those distal fragments, because oftentimes if we make our incision too short or proximal, we're pulling the skin back and we don't see distally as much as we would like to. So I would urge you to think about this extra inch to your incision, because that's actually where the fracture is. The fracture is much more proximal. So here you can see where the fracture is and where the incision carries on. So it's important to know the anatomy here. So what do we see? So you can see as you come more distal, the superficial branch of the radial artery becomes into place. So you need to watch out for that. You have the median nerve. And remember, just ulnar to the FCR is a palmocutaneous branch of the median nerve in most cases, but not everything. And I'll show you an article why that's important. So what you do is once you're through the skin, you release the FCR volar sheath. And then this is the critical step. You find below the FCR, you find the FPL, and there's this thick septum that you have to release all the way to the scaphoid tuberosity. And by releasing this, you get this unparalleled view of the volar aspect of the distal radius. And remember, you can see this extra inch of an incision here, which allows you to see everything distally. The next thing you have to release is the radial septum, and the radial septum essentially is the brachioradialis, which is the deforming force for the distal fragment. So I would urge you in all cases, for me, I release the brachioradialis. You're not fighting that reduction because invariably it's hard to reduce that distal fragment all the way ulnarly. And this is that watershed line that you can see that yellow line, and you can see the pronator quadratus just proximal to this, that red line. So between this is that transitional fibrous zone. And this is why the extended FCR approach is important, as because here what you can see, we've identified the watershed line, the most distal aspect of the distal radius. You can put your finger in and just feel where the edge of the distal radius is. And there you can see the transitional fibrous zone between the distal aspect of the pronator quadratus and the most distal aspect of pronator quadratus and the distal aspect of the radius. And so you raise that layer And now you can see by doing this, you can really get your plate as distal as you can. And more importantly, those very distal fragments, you can actually see them. And so we're elevating the pronator quadratus. This is, you all do this. And then you take a lobster claw and pronate out the distal proximal shaft. And this allows you now to get back to the radius. And here we talk about reduction. So you can see in this cartoon, this hematoma between the fracture fragments. But by doing this, you can now get your curette out the hematoma, and then get your reduction. So here you can see with that shaft pronated out of the way, you can get to the distal aspect of the distal radius, remove any of the hematoma that may be blocking your reduction, and then supinate the radius. Remember I mentioned that most of the time, the palmar-cutaneous branch of the ulnar nerve runs ulnar to the FCR, but not all the time. This was a study out of our colleagues in Pennsylvania where they noticed that in some occasions, the palmar-cutaneous branch of the median nerve ran from ulnar to radial. So as you're coming through to the FCR, remember to spread, don't cut straight down, because sometimes you might injure this nerve and you may not see it at the time, but these patients can have a devastating neuroma postoperatively. What's the second top tip? So the second top tip is paying attention to plate placement. And this relies to the watershed line. So you can see at the very distal aspect of the distal radius, if you look at this cadaveric prosection, look how close the flexor tendons are to the edge of the distal radius. So that's why your plate cannot be right at the watershed line. It needs to be a couple of millimeters proximal to this. So if you look at this case example, and if you just look at the distal radius fracture, it looks good. You've got good restoration of radial height and inclination, and the volar tilt is reduced. But if you look at the lateral radiograph, if you draw a line along the volar aspect of the radius, you can see that that plate is volar to that line. And this was described to us by Max Sung. And basically what you want to have is have that plate either on the line, but ideally dorsal to the line. If it's volar to that line, you're going to irritate the flexor tendons. And so here you can see why that happens. You can see the plates being placed, but look how close the FDP of the index finger and the FPL is. So if that plate is too distal, these are the two tendons that are going to be irritated most. Number one, the FPL. Number two, the FDP of the index finger. So this is a patient that came to see me, I showed earlier, and didn't show you the lateral radiograph, but you can look at the lateral radiograph, how that plate is off the bone and the screws are backing out. And if I draw that line, you can see how that plate is volar to that line. So I took her to the operating room, and you can see here how the plate is draped over the flexor tendons over it and the median nerve. What's the third top tip? This is the importance about getting an adequate reduction. You've got an adequate exposure. You know how to place your plate on, but remember the plate won't get all of your reduction. You have to work to get your reduction. So here are some top tips here. Number one is about releasing the brachioradialis, because if you release this, you can, for example, put a Hohmann here, lift up that proximal shaft and reduce that distal fragment to the shaft. And then you can put K-wires to hold it to get your stabilization. And then when you're putting your screws, remember that I showed you that axial view. You do not need to be out the back of the distal radius. Studies have shown that if you're about 3/4 the length from volar to dorsal at 75%, that gives you enough biomechanical stability, especially that these are using locking plates. And in addition, when you're drilling, put your finger on the other side and use that as a tactile feel so you don't plunge and get the extensor tendon as you're drilling. We talked about the sigmoid notch, and this is why this is important. You can see on the bottom right that sigmoid notch is off. And if that is not reduced, these patients may have DREJ problems moving forward. So it's critical to reduce that sigmoid notch. The other thing I mentioned to you about is radial translation. This is a nice technique described to us by our friends in Brisbane, Australia, Mark Ross and Greg Cousins. And I urge you to read this paper to help you try and learn this technique. And the premise of this is this: when you look at a normal radiograph and you draw a line along the ulnar aspect of the radius, it should bisect roughly about 50% of the lunate. Okay, so a line from the ulnar aspect of the radius straight through should bisect roughly about the center of the lunate. So this is a patient of mine, and you can see here, this is malreduced. So I've got my fixation distally, but when I draw a line along the ulnar aspect of the radius, look at where it bisects in the lunate. I've only got about the ulnar quarter, and that's because that distal fragment is radially translated. So now what do? You've got all your screws in the distal fragment, you take it all apart, it's going to be harder to fix. So this is a nice trick. So what you do is you back out that central oblong screw, and you can see there a lobster claw between the ulnar aspect of the shaft of the radius and the radial aspect of the plate. And so you simply then close that together, and that will bring that distal fragment from radially to ulnarly placed. So here you can see pre on the left and post reduction on the right. You can see how by me doing that, I've corrected that radial translation. And that's why it's important to release that brachioradialis, because if you don't release it, you're going to be fighting that when you're trying to get the reduction. What's the fourth top tip? How to prevent intra-articular hardware. I showed you an example of inadvertently putting screws in the joint. How do you prevent this from happening, which is a disaster? And so you really need to be comfortable looking at these tilt radiographs, and you can see how by moving the radius and getting your tilt view, when you get more tilt, you can see the lunate facet. You can see here, less tilt, you can see how you're looking at the radial styloid. So for me, in the operating room, this is the lateral radiograph, and you can see how the screw looks in the joint. Well, that's a radial styloid screw. So for me, when I'm fixing these, I always start on the ulnar side, and I put my ulnar screws in first. Because if you put your radial screws in your radial styloid, every time you take an x-ray, it looks like the screws are in the joint. So what I do is fix the ulnar column first, get the tilt lateral radiograph like I've got here, and then I put my radial screws, because then I know I have not put any screws within the joint. This is useful, the pronated oblique view, to make sure your screws aren't coming out the back, especially for the styloid. And here's the dorsal ulnar view in ensuring that the screws aren't out the back for that. Remember that dorsal ulnar corner fragment. And here's the tilt AP. But I think the tilt radiographs are critical when fixing these. I've also used this a lot now, the dorsal tangential view. I think this is an important x-ray because of that initial cartoon when I showed you, to prevent your screws from coming out of the back. I find this view particularly helpful. So what you do here is that you get your forearm parallel to the x-ray beam and extend the wrist. And the reason to do this is because it gives you an unparalleled view of the sigmoid notch. And so here you can see how those screws have kept short, because what you don't want to do is you don't want to do this. You don't want to put your screws into the sigmoid notch, miss it in the operating room, and then the patient complains of pain in pronosupination. So for me, at the end of the case, I'll always get this extended DRUJ view and then flex the wrist down to look at the screws to make sure they're not coming out of the back. Fifth top tip, to look inside the joint. Don't be afraid to look inside the joint, especially for articular reduction and for the hardware. When it doesn't quite look right, you've got your best reduction, but there's a step off and you can't figure it out. Is it real or is it not real? Look inside the joint. So this is a patient of mine who you can see has an intra-articular distal radius fracture. This is the reduction radiographs in the emergency room, and you can see, especially on the lateral view, you can see there's that step off, how it's impacted on the volar side. Here's a CT scan, and here's the axial view. So how do I fix these? So what I do is I try and get the best reduction I can. Okay, and so here I've got the best reduction. I've put the plate on. You can see proximally the only fixation I have is in the shaft, nothing distally apart from K-wires. And if you critically look at that x-ray, there's a double density. So I'm off. No matter what I'm trying to do, there's a double density. So then this brings us to arthroscopic visualization. So here the camera is in the 6R portal, and we're irrigating the joint. And what you'll see is hematoma after hematoma. But you take 10 or 20 cc's and you lavage the joint, and then you get this unparalleled view. You can see the cartilage looks pretty good, but as I switch the camera around, you can see that I'm actually off on that dorsal ulnar corner. So here the dorsal ulnar corner was slightly malreduced, just a couple of millimeters, but you can see when you take the arthroscope, it wasn't a couple of millimeters just at one area. You can see how there's that large step off. So by not committing to screws distally, I can now back out the screws and get my reduction. And this is a technique taught to us by Paco del Penal, and I'll show you a video about how to do this in another case. But if we look at the schematic here, what we've done here is got all our fixation proximally, but distally, all we have is K-wires. So then we go into the arthroscope, and you can see now, because we've not committed our fixation distally, we back out the K-wire, you take a shoulder probe, you can disimpact the fragment, get your reduction, advance the K-wire, and then fix your ulnar column first, and then move on to your radial column. So you can see in this patient, what I did is pulled out the K-wires, got my reduction, and then put my screws in. And these are the final radiographs. And you can see on that lateral view, that double density has gone away. What about this patient? So this patient comes in a comminuted distal radius fracture. And now look at the CT scan. Remember I mentioned about the sigmoid notch, but you can also see the articular incongruity. And then you can see there's a fragment flipped into the sigmoid notch. So how are you going to address this all from a volar approach? So here what I've tried to do is get the best reduction I can with a plate. And so you can see I've got the best, and this is not anatomic, but this is the best I could do from a volar approach. So you can see I've got fixation proximally, but distally all I have is K-wires. And now here I am, you can see the camera is in the 6R portal. And the reason for this is because what you don't want to do is have the camera pushing down on your fracture fragments. And invariably the distal ulna in most distal radius fractures is not fractured. So here you can see I've just made my 3-4 portal. And remember, all your bony landmarks have gone now. So now you can see this is the automatic washout technique. You've got the camera in the 6R portal. And what I'm doing is lavaging the joint, because once you're in there at first, all you're going to see is hematoma and you'll get frustrated because you can't see. So I think in this patient, I used 10 or 20 cc's to just lavage the joint. So another 10 cc comes in and we're just going to irrigate the joint. You can see in the radial styloid, all we have is K-wires. So we're going to lavage the joint. And then this is what you see. This is a different patient, but I wanted to show you after lavaging the joint, you can see in this patient, this is the CT I showed you, you can see how we're off there. So I've debrided the callus. I'm now pushing on the reduction, and now I've got the camera holding it and I'm holding the reduction. And my assistant now, because of these plates now have these fixed angle guides, can now drill and put the screws in. And you can see I'm holding the reduction while he's doing that. Now we go to the radial side and look at this. Now we're debriding the joint and you can see that that radial styloid is stepped off. And so here we're debriding it away. And now we use the K-wires to over distract and get our reduction. So you can see how we lifted that up. And then here's the final fixation. So here are the post-operative radiographs. Again, not perfect, but now I feel I've addressed that joint better than what I could do with just doing it from a volar approach. Top tip number 6. As you know, not every fracture is amenable to volar plates. And you can see in some of these highly comminuted or these marginal rim fractures, a volar plate isn't a good idea. So that brings us on to different forms of fixation. For example, a bridge plate, which is essentially an internal external fixator for these comminuted distal radius fractures. Very good in terms of these patients who have other injuries, such as bilateral lower extremity injuries, where they have to weight bear on their upper extremity. And the reason why this is more biomechanically stable than external fixator is this study by Bobby Chabra basically showed that by decreasing that bone to bar distance that you get from an external fixator to an internal bridge plate, you're getting better rigidity. So this is a patient of mine, you can see has tibial plateau fractures and this comminuted intra-articular distal radius fracture. And you can see has that volar rim fragment as well. Remember, always look for that volar rim fragment. We'll talk a little bit more about why these are so important. And so this is one of my partner's intraoperative photos of a different patient, Dr. Bakri. And so here what you're doing is you're making an incision over the index finger metacarpal and proximally. The key image to note is this one on the left. You want to get underneath that fascial plane, because if you're superficial to that fascial plane and you push that freer elevator, you're going to get the extensor tendons. And so if you come underneath that fascial plane, so you're pushing onto bone, push that freer elevator, now you're delineating this nice pathway. You can see on the right image how you've got that nice pathway and the plate will then pass. It's critical you do that, because if you don't, you're going to get the extensor tendons. So here you can see the plate has been placed. And what I would say with a bridge plate, like an external fixator, is get your best reduction you can first, hold it with K-wires, and then put the bridge plate on. The bridge plate is great for getting your length back, but is not very good at getting your radial inclination or your volar tilt or articular reduction back. So here you can see the plate has been placed. There's K-wires. So the AP, look at the AP radiograph. The AP radiograph looks pretty good. But remember how you critically need to look at your x-rays. If I look at the lateral view, there's a double density there. And so that double density is because I'm off on the articular reduction. So this is why I've said to you, bridge plates don't get your articular reduction back. You have to get that back. So here, what I noticed is that I then went volar, and actually there was that volar fragment that I showed you had shifted. So here I just put a buttress plate, and here you can see the CT scan showing how I've reduced the articular surface. But there are issues with the bridge plate. As you know, you have to immobilize the wrist for at least 2 months, and then you have to take the plate out. So I wouldn't say it's needed for every fracture, but some of these very difficult ones certainly can help you. Well, what about these fragments here with these volar rim fragments? These are those type of injuries that once you've seen it once, you should never forget about it, because it will bite you if you ignore it. So this is a patient of one of my partners. You can see the plate has been placed, and to ensure that the plate wasn't placed too distal, you can see K-wires have been placed. And when the K-wires have been pulled that were capturing that volar rim fragment, you can see you have volar subluxation of the carpus. Now that's very difficult to salvage. You have to go back in. There's a lot of scar in the way, a lot of callus. The tissue planes aren't clear. And so to salvage this can be difficult. This is nothing new. This was shown to us many, many years ago of these patients with volar shearing fractures, all treated with a volar plate, all had carpal subluxation and failed and needed subsequent surgery. So top tip number 7 is learning about fragment specific fixation. I think this is important in 2021 and moving forward. It's not needed for every fracture, but certainly when you need it, it certainly can help you. And so here you want to need to understand the columns of the wrist. You essentially have the radial column, which is everything radial to listus tubercle. The intermediate column, which is between listus tubercle and the DRUJ, and I'll show you why that's critical. And then you have the ulnar column. And if you look at the fracture fragments, there's a myriad of different fracture fragments. And so you can have the volar ulnar corner that we've talked about, which is critical. And then you have the dorsal ulnar corner, these free intra-articular pieces, and the radial column. Now, these are those truly dusted distal radius fractures. So in terms of the column theory, we talked about the radial column is the radial styloid. The intermediate column is the dorsal ulnar and the volar ulnar corners. And this is critical because this is a sigmoid notch. And Dick Berger has taught us many years ago how important that is for the foundation of the distal radius. And the ulnar column is the distal ulnar. So how do you start when you have these patients that are significantly comminuted? Build from the strongest foundation of the wrist, and that is the sigmoid notch. So what you want to do is restore the volar ulnar corner first and then build off this. So the order of fixation is you go first volar, fix the volar ulnar corner, then go dorsal and fix the dorsal ulnar corner. Now you have a sigmoid notch and you can build off this. You then fix the radial column, and then the last thing to be fixed is the ulnar column. So let's look at this patient. So here you can see this highly comminuted distal radius fracture. You have the radial column, free intra-articular pieces, and you can see it has a volar rim. And look at the articular surface, it's completely disrupted. So at first this patient was too swollen, so I put him in an external fixator to get the swelling down. I then went volar, fixed that volar ulnar corner first, but you can see here how I've kept my screws short. So I got that volar ulnar corner buttressed and then kept my screws short. I then went dorsal. We talked about arthroscopy, but if you're not comfortable with that, you can do a mini open approach. And this is a case by my partner, Dave Dennison, who shared this photos here. You can open up the capsule, you can disimpact the articular surface, put bone graft. And now back to that case of mine, we fixed the dorsal ulnar and the intermediate column, and then finally the radial column. What about this patient? This is an elderly patient with an open distal radius fracture. So we have to take this to the OR and wash it out. But look at the how distal it is. To capture that with a volar plate would be difficult for 2 reasons. Number 1, I may be past the watershed line. And number 2, I could put screws within the joint. So here what we've done is we've reduced that fragment with K-wires, and then we've put this volar hook plate. And this is designed to allow you to go as distal as you can to capture that fragment. And so here you can see I put 2 of these plates on and then put these screws to buttress it up. So by understanding the principles that we've talked about, it'll hopefully keep you out of problems. And you can see these are low profiled, and she went on to do well. We talked about the intermediate column, and this is critical. So this is a patient of mine who has bilateral distal radius fracture. So if you look at the right side, that looks pretty straightforward, not a problem. You can see the CT scan, and I fixed him. So that was the one side. Now look at the left side. I urge you now to remember this case example moving forward. When you see these patients, and you can see they have this split this sagittal split through the distal radius. Remember that the majority of load bearing is through that intermediate column. So you better get good fixation. So this was a technical failure of mine. You can see I thought I had 2 good screws into that intermediate column. Patient being weight bearing, and you could see comes back 2 weeks later. But I think this was a technical failure on my behalf. And you can see how that ulna, that intermediate column has sunk because I didn't get good fixation of that intermediate column. So when you see these, just think about how the fixation that you've gotten. And you could see I actually only had 1 good screw in that fragment. So this now was a harder salvage. And so essentially we treated this with a bridge plate and fragment specific fixation. And overall, he ended up doing well. But when you see that intermediate column, really think about your stability that you've gotten over this. We reported on fragment specific fixation many years ago, and I think the principles hold true today. The order of fixation is what I talked about. In terms of our clinical results, these patients did okay. In terms of our radiographs, that normal teardrop, that volar ulnar corner, you should see is about 70 degrees. So we failed, it's about 55 degrees. But what we notice is that you have to follow these patients. You can see 4 of these patients needed hardware removal. None went on to tendon rupture because when you're putting these plates, sometimes they can irritate the soft tissues. So you have to follow these patients carefully. So I think in summary, what I wanted to show you is that it's really important when treating these fractures to really understand the radiographs. And if you need to get a CT scan to get a CT to understand the nuances of the fracture, it's you, the surgeon, and not the hardware that's the most important determinant for outcomes. Number 1 is the nature of the fracture. Number 2 is what you do. Because if you malreduce these or malfix these patients won't do well. I think it's important to really consider the age and the activity level of these patients. You know, there's a very different from an 80-year-old that stays at home to an 80-year-old that's out there playing tennis or cricket. They should be treated differently. And remember, don't forget about treating osteoporosis. This is critical. Oftentimes as orthopedic surgeons, we're the first people to actually recognize a fragility fracture. I think it's important to understand the fracture from the x-rays and CT scans. And then from this, increase your wheelhouse of techniques to treat these fractures. I've shown you different ways to fix these. Not everyone suits all. In the operating room, I think using live fluoroscopic imaging is critically important. But if you're not sure, look inside the joint and either do that from a dorsal approach or you can use arthroscopy. Lastly, what I wanted to share with you is something that's exciting from the American Society for Surgery of the Hand regarding education called HAND-E. This is basically the electronic platform that is geared for medical students all the way through treating physicians, and it's free. And so the key things in terms of trainees is last year, Professor Boyer, as part of his presidential theme, basically got 50 lectures. It's actually now more like 100 lectures from leaders all over the world in their field to give dedicated lectures. We have a curriculum that comes out every week. We have a fellowship debate series that happens every month. And then we also have a comprehensive review, again, which is free for those for studying. So this is what it's like for the residents. You can see this is an example here where you have the topics and you just click on these topics and it will take you to dedicated teaching. This is what the Hand 50 series are like. These are videos from experts in the field. You can see there's one of the most popular videos is this one by Dr. Kleinman, showing you actually how to examine the wrist. These are the debate series where you have different debates for topics that are confusing. For example, scapholunate ligament injury, Kienbock's disease, where you have different people going over techniques to give you the gamut of treatment options. The fellow shoe is a weekly email that goes out to trainees for areas that are critical to hand surgery. And there's a resident reading list. We also have this video theater competition. So I urge you all to submit an abstract, which is basically a surgical technique. These are due by 15th of March, where you submit a surgical technique and then are invited to submit that surgical video. And there's a competition. The best ones get highlighted at the annual meeting. And I'm proud to say a month ago we started this. This is called the Hero Series, and this is for those surgeons in practice who don't have time to look at a lot of topics or debates, but they want to know pearls. They want to see surgical technique videos. So this is something that you subscribe to. Again, it's free, and then this gets sent to you. And you also get a relevant article in the Journal of Hand Surgery to give you a little bit of more knowledge on that topic if you're interested. And finally, the comprehensive review course. This is basically those who are looking to sit an exam where there's dedicated exam-related lectures with questions that are pertinent for the exam that you can again access for free. And you can simply do this either on your computer or download this app. So thank you very much for your time. And if you have any questions, please do not hesitate to contact me. Thank you very much.
Thank you, Prof. Sanj, for that huge journey, the comprehensive journey from close reduction and cast to through arthroscopy and fragment-specific fixation, and all your top 9 points, the tips. It was amazing journey, and then if at all we've taken those golden nuggets in our practice, I think this is one of those lectures which I think the Pune Orthopedic Society has to store for its archives, and then needs to repeat it every time somebody has doubts on these kind of things. Thank you so much. And
that's very kind of you, Professor Bhatt.
Abhijit, do we have questions or from the audience, or do we go ahead with?
I think we could go ahead with the discussion and questions that you could address to Professor Sanj.
Okay. I've gone through your the recent articles, especially with those huge data, the big data of 34,000 patients, and then the 13,000 patients of the non-op kind of thing. And one was for the younger age group, 18 to 64, and the other was above 65. And whenever I've seen that, the operative versus non-operative, and most of the time it's that at 1 year everything kind of equalizes, most of these kind of fixations or treatment options. And then you always told in that both these articles that the one year post-op kind of outcome is stiffness in operative groups, and the non-operative groups come back with for secondary procedures, especially carpal tunnel releases and those kind of things. How do we quantify this stiffness? I mean, I was not clear on what is stiffness in terms of 1 year post-op when you talk of outcomes of all these kind of operative procedures which you ran us through, and what is stiffness for a patient, and what do you judge as a stiffness?
Yeah, it's a great question, Professor Bhatt, and I would say it's very subjective in terms of what somebody says stiffness is. Stiffness in a manual laborer is very different to somebody who's retired. And so for me, it's a clinical judgment compared to the other uninjured side. And we know for distal radius fractures, it can take up to actually 2 years to fully recover from a distal radius fracture. So for me, the stiffness is, there's 2 ways. The objective way is comparing it to the uninjured side. But to me, it's more of a subjective thing of, can you do what you need to do without issues? And to me, that's how I quantitate stiffness. In the study that you kindly mentioned, that is from a database. And so it's very hard when you're looking at a very high level to get to the nuances. But when you're practically speaking, stiffness to me is, while we note down the clinical measurements, it's more of a, can you do what you need to do? And if you can't, how can we get you out of that? I think it's, if somebody is stiff, I cannot recommend how important therapy is, and do not pull the trigger to go in straight away to do, for an example, a release or a debridement. I think therapy is an amazing tool that we tend to not use too much, but I think has significant advantages. And for me, for stiffness, if I'm thinking about treating them operatively, I would wait at least a year before pulling that trigger of doing something operatively.
Thank you for clarifying that. Abhijit, do you have anything to ask?
Yeah, I have a rather pressing question. We've all heard about Paco Peñal's take on CRP as being a result of a nerve injury. Whereas we all have grown up thinking about CRPS1, where there's no organic nerve injury, to be also an important cause of RSD or CRPS. So what is your take on this particular aspect that really complicates an otherwise well-done distal radius fracture fixation?
Yeah, it's a good question. And Paco is obviously a thought leader and has taught us so much. And I think he's onto something about these patients that come in after surgery, actually, or not even having had surgery, and beforehand were fine, and they have this sort of stiff hand. Now, it's interesting. Some of them may have carpal tunnel symptoms, and you can elicit those clinically, but some of them won't. And you'll tap over the median nerve, and they don't really have classic numbness and tingling. But what Paco has shown us is that maybe these patients do have median nerve neuropathy that could benefit from a carpal tunnel release. I know we like objective criteria, and sometimes I've tried to inject these patients, and if they've gotten better with an injection, we'll then do an operation. But sometimes they don't respond to the injection, so you're sort of left, well, should I do this procedure, which potentially could make CRPS worse if we're thinking it's caused from surgery? And so I'll have an honest discussion with our patients. And most of the time, because the morbidity of a carpal tunnel operation is minimal, they will elect to go forward. And I have seen patients actually do very well from this. And so I think he's certainly onto something. I just feel that we need to get better objective criteria about who to offer that procedure to, because I do worry at the back of my mind, if somebody has these symptoms and you do an operation, you could potentially make it worse. So I always make sure that they truly understand that, and it's truly an informed decision if they decide to proceed with surgery or not.
Great. And so may I just ask one more question,
please?
Yeah. So for these very distal radius fractures, they've shown releasing the transitional zone or using a plate right up to the lip of the distal radius, and especially in an elderly patient, would you perform a prophylactic carpal tunnel release?
Yeah, no, great question. I tend to ask these patients if they've had carpal tunnel syndrome in the past. Before their injury, did they wake up with numbness or tingling? Do they have a history of that? Obviously, if they have carpal tunnel at the time of doing surgery, I'll do that. But if they've had a history or a prodrome of carpal tunnel syndrome, then I will consider doing a carpal tunnel release. However, I won't do a prophylactic carpal tunnel release on every patient. There's good data showing that actually you can make it worse just by releasing the carpal tunnel.
Thank you.
Continuing from what Abhijit was talking about in terms of the CRPS, and you said about the median nerve neuropathy, is it something related to the mobility of the nerve itself in terms of the scarring which happens after the surgery? And then we know that a lot of ultrasound studies talking about the mobility of the nerve and reduced mobility of the nerve, and then so is there a role for before taking a decision on carpal tunnel release? As you said, yeah, the signs might be there, might not be there. Do we really have to see the mobility of this nerve? And as you again told, the therapy is very, very important. So nerve gliding exercises, do they have any of these roles? Ultrasound,
yeah,
or gliding exercises, any of these?
It's a really astute question, Professor Bart, and I'm glad you mentioned that. Peter Amadio at our institution is doing a lot of innovative research on the role of ultrasound and nerve gliding and the subsynovial connective tissue gliding in carpal tunnel syndrome. I think what you just mentioned is a great example of how ultrasound potentially could be one of those tools. I'm not aware of any literature about it, of using it in patients that you suspect have carpal tunnel after surgery. Maybe there is a role of ultrasound, not only just for maybe an injection, but actually, yeah, seeing those patients who you scan everybody and look at the gliding. And it may be that those patients who have scarring around the nerve actually are the ones that should be indicated for carpal tunnel release, as opposed to those who have free gliding of the nerve that may not benefit. So I love the way that you've just mentioned that. I think that's a study right there that you've just mentioned that hopefully next time you've answered that question for us.
Yeah, we do a lot of ultrasound. Abhijit knows we do a lot of ultrasound for the wrist. for all aspects of the wrist, and this is one of the areas which I'm really interested in. And so I thought whether we could connect that with the CRPS or not.
Yeah.
Yeah. And I've seen that in your talk, you kind of excluded the external fixator. You went on to the bridge plate. But in India, the scenario is that people use a lot of external fixators even now. And of course, if you look at the studies, again, in terms of the outcomes in the long term, yes, they might be same, but in the short term, they have more problems and complications. So probably the world has slowly given up external fixators. I have a case, Abhijit, with your permission. And we do get a lot of late present, as in treated outside in other hospital, and then they're referred to us. And so one of these cases, I just want you to have a look. I'll just share my screen.
I think Sanj completed his talk in absolute spot on time, 45 minutes. So we could have a case discussion.
Yeah, and I'm glad that you mentioned about external fixator. I agree with you. I think it's a wonderful tool. We tend to use it less often, but I was trained in London and in Boston, and I sometimes still use an external fixator. I think it's a wonderful tool. I think one of the critical things with external fixation or internal fixation is to ensure that you don't over distract the carpus, so they have good tendon finger motion. Otherwise, they can get stiff. But I think I'm glad that you mentioned it, because it is a wonderful tool, and I think we've become de-skilled in using it.
Yeah. Is my screen seen?
Yes, we can see you.
Yeah. So this was a 34-year-old male, open injury, 29th December, treated in another hospital with debridement, X-fix application. He was referred to us 2 weeks later, some healing raw areas. The wound looked clean. There was suture still there when he came to us. Patient did complain of some sensory disturbance in the median nerve distribution. And when we checked, he was also a newly diagnosed diabetes patient. This was his initial x-rays at the time of the fall. So all those elements which you told us to be careful, they're all there. You have these, the lunate facet areas, you have the carpal which is sliding off there. And would you like to comment on the x-ray?
Sure. Yeah. So this is a highly comminuted, very distal fracture. You can see on the left on the AP view how you have some ulnar translocation of the carpus because of that radial styloid fragment, which is relatively large. Now, usually if one can restore that radial styloid fragment, that will control the ulnar translocation. You can see in the oblique view that probably looks like the lunate facet has flipped up and needs to be corrected. And you can see that on the lateral view and also on the dorsally as well. This is sort of close to like a fracture dislocation.
Yeah.
But this is a difficult fracture to fix, and I'm glad that you showed this, because I think this brings exactly, look at that intra-articular incongruity. So very, very distal. But when I look at if I look at the middle view on the right, you can see you have something to work on there in terms of getting that carpus reduced and held.
So those are the other views of the CT.
Yep. Yeah, no, that's a tough fracture. Absolutely. I'm glad you showed this. So I think, go on, please. Yeah.
This is how he came to us. You know, it was 2 weeks by the time he came. The X-fix was put outside in another hospital.
Yeah.
And there was this wound right at the area where you would like to go in. We thought that tendon was exposed, so we had actually planned for probably retaining the X-fix, but then, you know, tell him that we might go for a flap if required later on. But otherwise, we had to explore this. We were worried about the infection again. His sugars were slightly high when he came in when we came to our hospital. And this was the X-ray, this reduction X-ray which we got when he came into the hospital.
Yeah, so one thing I would say is when you mentioned you had some median nerve symptoms, and you can see his wrist is slightly flexed. I think when you have these external fixators, you really need to have them in neutral, not in that flexed position. I think obviously the soft tissues are critical. I do wonder, On the volar side, it was more of an oblique view of the wrist, but on the volar side, if one, say, for example, came from a volar ulnar approach, would you be able to come through that approach and buttress that up, that volar fragments? I think still leaving the external fixator on at the end would be helpful. But in my mind, this is about trying to support that volar column, that volar ulnar column, and fixing that radial column, and then holding him out to length with the external fixator.
Would you put an implant inside, looking at the wound now, looking at his sugar levels, or if you saw, I mean, he's 2 weeks down the line. So, when we go in with these kind of fractures, that the fragments are not really the way you want to be in terms of the consistency also. They're all, kind of soft fragments there, right?
Yeah.
So,
I think if he's infected, then not. It wasn't clear to me if it was a suspicion of an infection or if he was infected. If he's infected, then I would not put any hardware.
No, he was not, in the sense the counts were okay. The ESR, CRP was okay. The counts were okay.
Yeah.
It's just the wound, and he came from another hospital, so we were not really knowing exactly what we should be expecting inside once we open up. We did open up. That was the median nerve. I extended it to the carpal tunnel, actually, released the carpal tunnel, and then you see the contusion of the median nerve there, which probably was the one which is causing the symptoms.
Yeah.
And that's a fragment which you rightly pointed out in terms of that lunate facet, which is totally rotated. So that was a fragment seen here. Very distal fracture, and that probably the rotated fragment was the one which contused the nerve also, probably.
Yeah.
Yeah. So that's a fragment. As you said, yes, we started with the radial side, built up the radial column because this was kind of very soft fragment. It was rotated, it was lying free there. So I just temporarily put the wire. But what would you do at this stage? Would you go in for an implant for a plate?
I think so. No infection then, huh?
Yeah, it was fine. There was some granulation tissue. Otherwise, there was any signs of infection as such, frank infection. Yeah.
Yeah, I think what I would do is, I think what you've done is amazing. It's a great exposure. It's a great initial reduction there. I think for me, I would try and build a volar ulnar corner and try and have something to buttress that fragment as best as I could. It may not be a full plate. I think, given what you said, it could just be a buttress plate to hold that, and then build off that. So I'd probably do the volar ulnar corner. It looked a pretty good size. Leave the pins and the radial column in. So at least I've got that volar sort of aspect built for the carpus to sit back in. The radial column is critical because you had ulnar translocation, and I would potentially be tempted to also leave the X-fix on as well.
Okay. Any thoughts on bridge plate? No.
Bridge plate, yeah, absolutely. Bridge plate works well. The issue is that with the bridge plate, you've already got the pins in place that have been already put in. And so I think that's why I said for me, I'd probably leave the X-fix on because, you've already got contaminated pins in theory.
Right. But I wasn't brave enough. I just left it there because with the sugars being high, I didn't want to put a plate there.
Sure.
Just left it there. And if you see the lateral, it's not so good. You see that fragment, it didn't sit well. As you said, maybe a fragment specific plate, a buttress would have been better. What do you suggest to hold that?
Yeah, how old is the patient?
He's 34.
And it's his dominant hand, huh?
Yeah.
Yeah, I think, honestly, it's like, I know you're a wonderful cook, but even if I gave you terrible ingredients, I don't think you could make the wonderful masterpieces that you make. So I think at this stage, you've already had a big operation. The fragments aren't the best. And I personally feel that the time that you went in is probably the best time you could try and do it. If at that stage, you couldn't make it any better. You had a horrible fracture to deal with. I would probably just let him heal.
So he's I think is now 4 weeks now. So just left it there. I don't know what to do, what to expect actually after another 2 weeks, at 6 weeks or 8 weeks, how this will heal. But otherwise, it is, as of now, it is kind of suspended animation for me. So I'll probably keep you updated what will happen with this. My main worry was, sorry, please
no, go on. You were saying your main worry was what?
Was putting an implant inside and ending up with infection, which he didn't have when he came in, and now I give him something new. I was not keen on that. Yeah.
No, absolutely. These are tough problems, and I'm glad that you shared this with us, because it brings up so many of the principles that we've discussed. You know, we try and aim for perfection, but as I said, you know, this was a tough fracture to deal with, and there is data showing that these patients actually do eventually go on to having some form of radiocarpal joint procedure needed down the road. You know.
Okay. Yeah, I mean, we had actually counseled him for a kind of a fusion in future, in terms of a radiolunate kind of a fusion, or even a radioscapholunate kind of a fusion. But then, I mean, we've just told him that, but otherwise we'll have to wait and see how he does at the end of a year probably, and then take a decision on that. Abhijit?
Yeah, so at the IFSSH meeting in Germany a couple of years ago, I think all of us were there. There was a beautiful presentation by a German colleague, I forget his name, and especially for such fractures where there's badly depressed lunate fossa or a die-punch fracture. So you do your best to reduce it, and then you put a wire across from the radius into the lunate, kind of offloading that area and allowing for the healing to occur. And even though if you don't have perfect looking x-rays, reduction x-rays, these patients go on to do very well, because the lunate is now offloaded. It's not directly pressing on that fragment that you've elevated. These are fragments where you may not have the best of your implants and abilities to fix it. So it's kind of just floating. And then as long as you're offloading it, it kind of heals pretty well. And then they go on to do pretty well. So just a thought. And I have tried that in a patient recently, just waiting for the outcomes. Once we see that guy again, I'll let you know how that thing works. So it's just something that came to my mind when I saw these slides and remembered that presentation from our German colleague. I thought it was a brilliant idea.
And Sanj, I should tell you that whenever I try to call Abhijit, he never picks the phone. So kind of advices I don't get when I'm in trouble.
I'm always around for you, okay, no problem. But I'm glad you shared that, because it was like that case that I showed of mine where it collapsed. I think having some form of distraction, you're absolutely right. If you can offload that lunate facet fragment and let it heal, you're absolutely right. And so wonderful discussion of a really tough case.
Yeah. Right. Well,
how are we on time, Abhijit?
I think we could perhaps it's 8:30, 8:40 almost here, so it's about 9:30 at your place, I believe.
10 past 9,
10
yeah.
o'clock, 10. So we won't keep you anymore, Sanj, on a Sunday morning. I'm sure your family is waiting for you. And thank you very much for this. I really, really appreciate it. And we look forward to more participation, more learning from you in the Indian hand and orthopedic scenario. And we would also want you to teach us, especially our residents, about how to go about research and publishing and getting involved in scientific activities. This has been a great teaching, and for both of you, Anil and Sanj, you have my deepest gratitude for doing this for us. This video will remain on the website, on the YouTube channel for people to see and learn from for posterity. Thank you very much, and warm regards to you all. Stay safe.
Oh, well, thank you, Abhijit, and thank you, Anil. And Abhijit, I still remember you fondly when you came here to Mayo, and sitting at Starbucks and having a coffee together and just talking. That's how our friendships have developed. It's lifelong, and if I can ever help, happy to do so and honored to do so.
Thank you so much. It's an honor and a privilege, and I really cherish your friendship and the learning. we'll keep in touch and keep advancing knowledge and science. Really appreciate it. Thank you.
Thanks, everybody. Take safe.
Thanks, Anil.
Bye-bye.
Thank you so much. Good night. Bye.
Bye-bye.
Take care.